And you know, we're really pleased to have Tom here, and so give him a North Dakota welcome. Get him up here, and really let's get the show going.
Okay. Do you have a PowerPoint? How do we do things?
We'll just say it there.
Okay, that sounds good. It is. I don't. You know, I don't always say this, but it's really nice to be here. And I know you're kind of going, yeah, right. You drove to North Dakota, right? But I really enjoy coming up here. I like coming to North Dakota and South Dakota. I was telling Dan earlier that this is like I mean, Iowa's pretty laid back, but, and you know, like the biggest town we have is Des Moines, and it's like medium size. But you know, like Kansas is a lot of frontier, and some of it feels like this, but then they've got Kansas City, which drives you crazy. But this is just nice, and I appreciate coming up. And my experiences in both of the Dakotas have been really good people working to provide services in an environment that is a little more challenging. And so I want to acknowledge that what you're doing right now is you're trying to make sure that we provide services to the citizens of our state. And I don't know if anybody else has noticed, but healthcare is changing. Just kind of curious, anybody notice that? And I will tell you right now that my perspective is if we're in a time of healthcare reform, guess who has to do the reforming? Okay. Now the question is, who should be leading it? And is this going to be driven simply by the payers telling us how they're going to pay us to do things differently? Or because the payers can just dangle things in front of us to get us to incentivize us to change. The fact is, we are the ones who actually have to change the way care is delivered. We're going to have to look at our processes. We're going to have to use data to affect change. So one of my opening premises for you is that A, this is what I'm going to be talking about is provider-led transformation. And B, you guys need to be thinking about this from North Dakota's perspective. How do we create a sustainable environment for North Dakota with your uniquenesses, with your demographics, with your payer mix, with all the things that are going on? So this is about North Dakota, but this is also going to be about provider-led transformation. Make sense? By the way, the presentations that we're going to do today have been done, I think the largest group we've done is 160, and it's been done over the whole course of a whole day. So what you're going to get is and knowing that you've been in a meeting for a day and a half and you're brain dead already, so we're going to be smushing this together and you're going to be getting it in a shorter period of time. But I think we can do it with a smaller group. And so the only rule here is we're going to go kind of fast. Excuse me. We're going to go kind of fast, but we're going to go, this is not going to be a presentation. This is like a discussion. So it is absolutely okay with me if you go, wait a minute, I ask that you don't throw stuff at me, but seriously, let's just have a conversation about this stuff. The other thing, you've already noticed that I've coughed a couple of times here, and this is kind of a constant joke, but I get to the springtime and I get these seasonal allergies. And I'm okay until I start talking too fast, and then I'll start coughing. It's not tuberculosis or something, it's just seasonal allergies. So I just want you to know you don't need to worry about an infectious disease guy here or something before I do this, okay? So let's get started. Objectives for this presentation, we want to talk a bit about the MACRA legislation. A lot of, you know, anybody not understand that we got MACRA coming? What we're going to talk about is what does that mean? And it is watch my mouth, an absolute game changer. All of the stuff that's been going on with healthcare transformations historically, that's all good. But the fact of the matter is, Dan's got gray hair. I've been in this business since I came out of residency in 1986. And I've been hearing that someday it's going to change. Someday, someday, someday. It's here. Someday is officially here. This is not kicked down the can. The can won't be kicked down the road any farther. What's happening is the physician reimbursement is all this quality stuff's really going to be important, and their payment is affected January 1st, 2019. So we're at a point where it really is gut-wrenching transformation. It's really going to happen, and it doesn't depend on the presidential election. Okay, it's going to happen. We'll talk a little bit about that. So we're going to talk about the MACRA legislation, its timeline. We're going to talk a bit about this TCPI initiative, and then we're going to talk about the power of aims-based collaboration. That's really what we're trying to pull together here, by the way. I know y'all work for someone different, but you're here together, and the only way you're going to build provider-led North Dakota kind of context improvement is to begin to work together. So we've got to, and you guys already do, I mean, that's the way we do things in the upper Midwest. So you kind of get it already. But now I'm going to challenge you that you need to yoke what you already do well and now try to figure out how we actually use that power to transform healthcare. Anybody ever heard of Don Berwick? I was going to say, don't tell me you've never heard of Dr. Berwick. Don Berwick is a pediatrician. He's probably the, not probably, he would be the premier for the last 30 years, the premier performance improvement guy in healthcare. He's been kind of driving healthcare and transformation. He started an organization called the Institute for Healthcare Improvement, and that organization basically drove provider-led transformation for a long time. Dr. Berwick was given the chance. Again, you got a provider, innovator, very, very successful national leader, and he was given the opportunity to literally come in and run CMS. Okay? So in 2010, Dr. Berwick was brought into CMS. Now, what's CMS? CMS, the Centers for Medicare and Medicaid Services. CMS is basically the world's largest insurance company. Okay? Medicare, Medicaid, X% of the American budget. So it's basically a big honking insurance company, and he was brought in to kind of run that. Why was he brought in? By the way, here's an interesting question for you. You know, all this stuff, things, you know, all this healthcare reform stuff, when I say someday it's officially here, why do you think it's really here? Why do you think we're really going to do this stuff? Ding. Basically, it's because we're broke, folks. We can't kick the can down the road any farther because right now our federal budget, you know, we all talk about our huge national debt, but that's been huge for a long time. The problem we have right now is the debt service. The interest on the national debt has gotten so large that that's beginning to challenge our ability to be able to pay our bills as a country. And we're about to take that difficult situation and overwhelm an unsustainable situation with volume as the baby boomers come of age and come into Medicare. Okay? So basically, if you're the feds right now, you're going, we got to do something. And they're trying to figure out how do we bend this cost curve in healthcare. So Berwick was brought in, performance improvement guy, healthcare guy, to run Medicare. Berwick, when he came in, he basically said, he went around to CMS, this is the world's largest insurance company, and he basically said, we're going to do things different. And these are the 4 pillars. He basically came in and he said, this is how we're going to do things now. Now, this is an insurance company. But number one, we're going to put the patient in the center. Now, here's an interesting thought. In healthcare, that's kind of unique because in healthcare, we don't usually put the patient in the center. We put the provider in the center. We're really a provider-centric system. What do we want to sell people? Oh, you'll come to our hospital and we'll work you in time, or we'll schedule an appointment for you, but it isn't really patient-centered. So one of the key points is, again, patient-centered care. Number 2, transparency and openness. Those feel like new terms for us over the last decade, because the fact is we're now using data differently than we've ever used data. And it isn't about using the data to compare you hospital A versus hospital B. It's not about that. It's not about clinic provider A versus, it's not that comparative reporting stuff. We can't transform healthcare if we don't know where we're starting from. We need the data. We need to know where we're starting, and then as we do change, are we improving? So there's a real commitment to data. We need to eliminate the waste, and we need to have a commitment to continuous improvement. You know, that's really saying 2 things, but it's estimated that of all of those dollars in healthcare, probably 40% of it is due to duplication or things that didn't really need to be done. Now, I know none of you ever have any of that stuff in your systems, right? We never duplicate anything, have any waste. But the fact is we're wading in so much duplication and waste that, frankly, think of it this way. If we're about to overwhelm the system with volume, we've got to find the capacity someplace. So let's squeeze the waste out of the system so we have enough resources to take care of the new people coming into the system. The only way we're going to do that is with a commitment to performance improvement. Wait a minute, we're good docs, we're good hospitals, we're good. Well, it's not about being good. It's about execution. Don't you love it when your kids text you? I always look at, by the way, I always look at my texts because I have an 86-year-old father who lives by himself. So I actually had this happen to me the other day. I'm in front of a meeting of about 50 people, and my phone rings. And it's my dad. He's farming. I mean, he's still working, but it's like, you not take your 86-year-old father's call when he calls. It's like, you sit here and go, he's probably going to say, I'm having chest pain or something. So, you got to take the call. But anyway, so we have to have a commitment. If this change has to be provider-led, we need to acquire the skills to be able to change those processes. We weren't trained in that, but we've got to have those new skills to do that stuff. And then finally, yeah. Yep. Yep. Yeah. Yep. Yep. So are you a doc? Okay. Are there any docs in the room? Okay. So, well, first of all, thank you for saying that. But what I'm going to ask you to do is let's just think of these as context. Okay. Because I agree. Matter of fact, we could go off on an hour on this one, but in the current volume-based healthcare system, one of the ways that they decrease the amount they spend on volume is to put administrative crap in the way so that it's harder and harder for us to do things, and then eventually it just reduces the unit cost. So I'm not arguing on that, but what they are saying, I think what we've all got to say is, okay, how can we improve how can we squeeze the crap out of there? And it's not all docs. Yeah. 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 You just went into like another whole lecture, which you're exactly right on. Matter of fact, let me touch on that piece, just on that. If you took a pie chart and you looked at where the cost is that we actually can bend, about 20 to 30% of it is healthcare, and the rest of it is either patient choice or social determinants of health. And the interesting thing is we're doing healthcare reform today, which feels like they just beat me over the head, is healthcare. But the fact is I think the challenges for healthcare is we need to tune our fiddle, and then we need to lead the efforts in those other areas. And kind of back to what I would say here is, I agree with you, but I think I don't want the insurance companies being the ones who are just the leaders on this. Yeah. 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 No, it isn't. It isn't. As a matter of fact, every system is perfectly designed to get the results it gets. And most of what happens with us is our reimbursement methodologies. So we've got a lot of work to do, but these are kind of glittering generality design principles that Berwick's saying to the world's largest insurance company, we got to do this different. And I would build the case, these are pretty much we need to do this stuff as well. So does that make sense? Okay, questions? Okay, so next slide. So I mentioned already, we're in the volume-based healthcare system. The feds have said we've got to eliminate the waste. They're moving to a value-based healthcare system. What does that mean? It means that when you think about where we are today in our volume-based healthcare system, it's how many widgets we can build. Anybody notice how that's working for us? what happens is when we start to top out how much they can spend, what do? They basically say they're going to decrease the unit cost per widget. And when they decrease the unit cost per widget, okay, then what do we have to do? Increase the number of widgets we're making to make up the difference. So, as a matter of fact, just to stay in business. So what's happening across the country is most providers are finding that they're just generating a whole bunch of stuff and getting paid about 40 to 50 cents on the dollar, which we can't just continue to just do that. It's not feasible. So what they're saying is, okay, let's, instead of just generating more and more widgets, let's start looking at the cost or the effectiveness per widget. And they're going to start paying for value. So now, this is not new. Talk about this has been going on for years. You guys know that. What is new is the feds basically put a timeline to it. So what you've got here is Secretary Burwell in 2015 basically setting some payment goals, and I'm just telling you what's going on. So CMS has said we want to move people into these risk-sharing arrangements, these ACO types of things. So we're gonna set a goal of 30% of folks being in a risk arrangement by 2016 and 50% by 2018. And how are they going to do this? They're going to put new incentives out to reward high quality care. They want to improve the way that we deliver care, improve care coordination, and they want to accelerate the ability of information to guide decision making. So more and more information. Next thing there, the point here is that when they proposed this thing and these great national goals, they basically described this TCPI project as one of the things we were going to use to equip folks to be able to do this stuff. So TCPI was mentioned with Burwell in the very beginning. This slide kind of talks about what they're trying to do. And moving from volume to value, and I actually was at a meeting last week. This is kind of a simplistic version of where they're trying to go. But if you look at the gray circles on the outside, if that's all of our fee-for-service payment, they want it to increase links for. Now, what does that mean? This is your math thing. Value is quality divided by cost. What I get versus what I paid for it. So if we're trying to improve the value, we're trying to improve the what I get based on what I'm paid. So to improve the value, you can improve the quality with the same cost. You can reverse it, but the bottom line is it's both quality and cost. Now, the only reason I bring this up to you is I want you to think back. There's a few people with gray hair remember the 90s. That was really Managed Care 101 or Managed Care 1.0. Okay, remember what happened when they did that? The insurance companies basically said, we're here to drive value, and they said, we're going to do managed care, and we're going to do these care protocols and all that stuff. And what happened was, you may remember, we couldn't really measure. How did we measure quality in the 90s? Anybody remember? We didn't have all this body of knowledge on evidence-based medicine. So what happened was, usually the way we defined quality was, where did you go to medical school? Do you throw things? I mean, it wasn't real good quality measures. And because of that, they were very subjective quality measures. Basically, improving value ended up being value equals 1 over cost. So in the 90s, the Managed Care 1.0 failed because we really couldn't build a good quality thing. What happens? The provider community said, wait a minute. I know it's less money, but I get sued if we do this stuff. Is this good medicine? And the provider community decided this is not good medicine. That really was the genesis of the whole evidence-based medicine movement, where we said, what things work, what things don't, do more of these and less of these. That was really, so the interesting thing is today, in the 90s, we generated a bunch of evidence-based medicine. We've continued to build that pile. We went through the 2000s where we began to standardize measures. And we're at a point now where we have better measures of quality than we've ever had. So the feds have said, okay, we're 20 years later now. Let's link those two together. Now we really can do value. So for all of my fee-for-service payments, we want to increase the number that we have quality measures for to 85%. And by 2018, we want it to be 90% that we have quality measures for. So at least for the volume-based fee-for-service measures, we can measure the value. So the feds want to be able to track that. The other thing they said, though, is that they want to try to drive us into risk-sharing agreements or risk-sharing arrangements where we agree to take care of a population of patients for something, and then we're at risk for the effectiveness. And their goal is that by the end of 2016, 30% of practices will be at risk. And by the end of 2018, 50% of practices will be in some kind of an advanced payment methodology. The feds really want you in these advanced payment methodologies, and it's going to actually move faster, and there'll be more and more incentives. Over time, you'll make more money in these types of arrangements, but these are to kind of help you get going. Interestingly, this goal of 30% by the end of 2016 has already been met. About a month ago, President Obama declared, hey, we've got 30% of providers or of dollars in an advance in a risk arrangement right now. It doesn't mean, it's interesting, it doesn't mean that 30% of providers are paid in that kind of a model, but 30% of the dollars in the country currently are at risk. Next slide. So enter the MACRA legislation. How many know about MACRA? Okay. This is a physician, this is Part B. So everybody kind of stick with me on this one, because the guts of this is the way physicians are paid is going to change dramatically. But first you need to understand how they were paid. Okay? Now, you're back in the 90s now. We're in managed care 1.0, and President Clinton is the president. And they've got this Part B pile here, and they can't get the Part B, the physician side of this thing, the outpatient side, to really begin to address the cost curve. So the Fed said, we've got to do this. We've got to bend this cost curve. How can we do it? This is what we're going to do. And they built this thing called the sustainable growth rate. And the sustainable growth rate, this is pretty simplistic, but the sustainable growth rate basically said, we're going to take this pile of money that we pay everybody, and every 3 to 4 years, we're going to reduce this pile by 2%. And if we reduce the pile, then the provider community will have to get efficient because there's less money there. So the great thinking was, we'll just make the pile smaller. And the provider community it'll be a little painful, but they'll get it and they'll adapt. Okay? So you can imagine, past in 1997, what happens? We get to 2001, and it's the first time we're going to actually reduce the size of the pile. And you can imagine what happened in Washington. The physicians, the AMA, everybody in the world came out of the woodwork. Whoa, you can't reduce our payments. You'll put us out of business. We'll quit taking Medicare. You can't do this to us. And Congress blinked. Congress said, oh, okay, we won't take away your money, but we're serious. So we won't take away your money now, but in 2004, when we come up to this again, instead of a 2% penalty, it'll be a 4% penalty. So you can imagine, so everybody, oh yes, thank you, we're serious, we'll do it. So you can imagine what happened. They go 2 years down the road, we get 2004, time to have a 4% reduction, and whoa, you can't do that. We'll go out of business. We'll take you. So again, Congress blinked and kicked it down the road another 2 years, but now it's going to be 6%. And this went on through 17 cycles. Now, after about the 4th or 5th of this, everybody's going, this is never going to work. We got to do something different. And they started trying to figure out what's an alternative. And they had to do something because they've already budgeted the long-term federal budget based on a reduced Part A component. So, and one of the things that was going on through all these cycles of the sustainable growth rate was the physician community was saying, you know, if you just paid us for quality, we'd be fine, because we're quality. We're quality doctors. I mean, usually when I have a room like this, I say, if this was a room of physicians, I've done this for 10 years. Imagine you're all physicians, and I'll usually ask, how many of you practiced in the lower 50th percentile? Okay? Do you know how many hands go up? None. Do you know how many hands have gone up in 10 years? One. It was someone in South Dakota. And they said, just kidding. but the fact is, you know, the provider community is basically saying, you know, the quality is a powerful driver for us. So they were saying, hey, if you're going to build some kind of an alternative mechanism, tie it to quality. So they did. So what we have, this MACRA thing wasn't going to work. They had to do something different, but they had to come up with some kind of a quality payment mechanism that would be budget neutral going forward. So they came up with this thing called the MACRA. What does MACRA do? The Medicare Access and Chip Reauthorization Act of 2015. It was passed in March of 2015, signed by Obama in April of 2015. It's very important for you to know this. Now, how many of your physicians kind of go, we'll get somebody else in office and this is all going to go away, or we'll repeal the Affordable Care Act and it's all going to be done? Has anybody ever heard that before? Okay, sometimes I'll hear that as I go around, and the fact is this is completely separate from the Affordable Care Act. The Affordable Care Act was passed, again, 2010, Democratic House, Democratic Senate, Democratic President. It was like a Democratic procto, okay? And what happened was, and when you've got a piece of major legislation like that, it's best if you can get a bipartisan passage. You can get everybody kind of, okay, yes, we got to do this together. Because if you don't, you end up with all this demonizing one party versus the other. You end up with kind of a, and it's made, the Affordable Care Act is made for wonderful political theater for the last 6 or 7 years, okay? But the fact of the matter is it just codified a lot of insurance reform that had been going on for the last 10 years before that. The MACRA is different. The MACRA is a separate piece of legislation. It was passed by a Republican House, Republican Senate, Democratic President. The passage, the Senate vote was 90-2. The House percentage was a similar percentage, so very strong bipartisan support, okay? The reason I'm saying that is this ain't going away, okay? The Congress of the United States has basically said the only way we're going to be able to balance our federal budget is by getting some cost curve built into Medicare and Medicaid, and it's going to have to happen through value-based reimbursement, okay? So just so you know, this ain't going away. Passed 2015, bipartisan support. The good news is it permanently repeals this kick the can down the road sustainable growth rate thing. It's gone. We don't have to worry about all that political stuff. But now it's making something different. Interestingly, what it does is it takes all of the providers and it kind of puts them back into medical school all over again and says, you're going to have to compete with each other. And what they do is they're taking, it changes the payment system for Medicare, and all providers will need to go into one of two payment tracks, okay? Either the merit-based and payment system, merit-based incentive payment system, or the alternative payment models. There are 4 categories for payment that have been ordained, if you will, and it starts like level 1, 2, 3, 4. Think of them as rungs on the ladder. The first rung is MIPS. The first rung is learning how to basically have the basic capabilities to be able to do stuff. And then 2, 3, and 4 are all alternative payment models, okay? MIPS, though, you have to go onto the first rung of the ladder. So I'm going to talk about the first of the rung of the ladder, MIPS, but I'm going to also tell you the reason I'm going to spend a lot of time talking about MIPS is that the second, third, and fourth rungs, the alternative payment methodologies, those have a lot of risk-bearing stuff, but the fact is the program I'm going to talk about, TCPI, only applies to equipping people to be successful in MIPS. The idea is basically, if you can't do anything else, everybody has to get into MIPS. MIPS will be something that gives you basic skills to be able to survive in those next levels, okay? So TCPI is about equipping you to thrive in the MIPS methodology. Next slide. So MIPS is what? Well, MIPS is effective January 1st, 2019. January 1st, 2019. What happens then? Your paycheck is altered, okay? So the guts is, and this is a hard point, folks. It's happening. And one of the interesting things is going around the country and talking to people about this, and many providers are going, what? That'll just go away with, we'll get a new president, or they aren't really going to do that to us, are they? It's going to happen, okay? So now the point is, if my payment gets impacted January 1st, 2019, what are they going to base that on? The predictions are that it's going to be based on your execution of the things we're going to talk about in 2017 and 18. So a 2-year ramp up will determine the rates and the grading out for the 2019 reimbursement. What are they going to grade me on? It's these little science projects they've been trying to get us to do for the last 5 or 6 years. PQRS, meaningful use, okay? Those things are like, those have gone from incentive programs to expectations to now penalties if you're not doing that stuff, okay? Well, there's a reason. It is what we're going to be doing. And now they've given us a ramp-up phase here, and now they're saying this is what we're going to be basing your payment on going forward. So value modifier, those are all, those different programs are going to be merged into what's called your MIPS score. And the clinicians are going to be given a score based on all of this other junk, and it's going to be between 0 and 100. And that score will be used to determine kind of what your payment's going to be. It could go up, it could go down, but the whole point is it is budget neutral. So we're taking all of the providers, all of your stuff is in here, and it's not getting any bigger. I've heard some people say, well, they're going to pay everybody for a higher MIPS score. They're not. They're not printing more money. This is going to be budget neutral. So the people who have lower MIPS scores are going to get paid at a lower percentage. Anybody have any questions on this so far? So let's look at that. Next slide. Okay, thanks. This may be hard for you to see, but let me kind of give you some of the timeline stuff here. First, I just want you to kind of draw a line right here. This is 2019, so there's pre-19 and there's post-19. Pre-19, what's going on? Well, we have these programs they've been trying to get us to do. We have PQRS and value-based modifier and electronic health record incentives. Those have all been in place. They're going to continue through 2018, but at the beginning of MIPS, those programs are gone. Those are now merged into your MIPS score. The SGR has been permanently repealed beginning last year, so that thing's already gone. And there's going to be some, remember they continue to kind of give us some updates on our payments, but look at what the percent, I mean, they're minuscule. We kind of hope they'll throw something at us. Well, now they're telling us what they're going to give us. It's going to be 0.5% in just basic payment updates for 16, 17, 18, and 19, and then they're going to 0. So just basic cost of living stuff, they're basically saying, okay, it's going into the MIPS score, and then they'll bring it back up and think about it, introducing it again in 2026. Okay? So don't count on just, they're basically saying we're going to pay you on performance. Now, on the merit-based incentive payment system, and again, this is everyone who's on the first rung of the ladder. Remember, the feds want 50% of us in the upper rungs by 2018. But for those who are just getting onto this thing and getting going, what's it look like? Well, the start of the MIPS measurement begins in 2017. Looking at your data, gathering the data, because it's going to be used to generate your payment. Your payment will be impacted in 2019. In 2019, it's an up or down 4%. The next year, it's up or down 5%. The next year, it's up or down 7%. And then 2022 and beyond, it's up or down 9%. So it's an annual risk to you. Now, there is another little thing down here for the folks in MIPS who leap tall buildings in a single bound, which means, you know, there will be a low percentage of folks that will do so well that there will be a very limited pool here to go to them. I don't even like to talk about it because I'm trying to, it's interesting when you look at this on the MIPS deal, in my opinion, it's not going to be just the bad doctors who are going to lose money with MIPS. It's going to be those who are not paying attention. Okay? So next slide. So this basically, in 2022, if I had to look at my MIPS score, what's it going to be made up of? And you look at these other programs, meaningful use should be about 25%. The idea is about 30% of it will be quality measures. And the thing that's important here is there are 2 new categories that they're going to start measuring us on that they haven't figured out how to do it real well yet. One of them is on clinical improvement activities like access and care coordination and patient satisfaction. They're going to have it at free. And then resource use. What's that mean? It means how good of a steward are we within our clinics. Like, case in point, a resource use example might be, you know, my brother comes into the office and he strained his back lifting a laundry basket or something, and he's just convinced he needs to have low back films. You need to get some back. No, you don't need back films. Yes, I need back films so bad. Oh, beating me over the head. I finally give him back films. Well, it was a good use. Number one, it's not diagnostic. It's not therapeutic. But it did expose him to radiation. Okay? So the whole point is that is a utilization measure that we'll get dinged for. So they're going to be looking at kind of, are we doing things to people we shouldn't be doing things? There's going to be an increasing body of those coming forward as well. Now, interestingly, remember I said this is 2022? Now I'm going to teach to the test. This is 2022. These aren't real mature. These aren't real mature. So there's going to be, what's your score going to be determined on in 2019? Next slide. This is just what we can see at this point. It's looking like for your MIPS score in 2019, probably 50% of it is going to be tied to your PQRS reporting, and another 25% tied to your meaningful use. So there's 75% of your score right there, okay? And then they're going to have us begin to work on resource use and process improvement. You'll see the percentage goes up on resource use over time, 10, 15, 30, 30. But we're staying about the same on process improvement, patient satisfaction, and kind of stuff. Now, the point I want to make on this one is, some practices still aren't reporting PQRS. Imagine you're taking a test and just didn't answer 50% of the answers. I wonder what that's going to do for your score. Okay? So if you're, get your people reporting. If nothing else, get your people reporting. Next slide. So this is a nice little cartoon that talks about great, we're chasing value, and they're driving me out of my brain because I can't go fast enough on this sale. But I want to challenge you on this. We sort of may feel this way right now as we're chasing quality. But where I want to challenge you is imagine, let's do this instead. Let's change this value to volume. Okay? Because what we're doing today is every cycle, it seems like we decrease our unit cost a little bit more, and we have to do more and more and more and more to keep the doors open. That's why they're making a change. They're starting to say, wait a minute, this isn't working. We can't just go on volume purely. We need to be looking at the value stuff. So now, if we've got to learn how to do this, that kind of brings you to the reason you're here, which is the Transforming Clinical Practice Initiative. What is this? Again, Secretary Burwell. This is a science project, okay? This particular project is not out of CMS proper, it's out of the Innovation Center. The Innovation Center does projects meant to try to demonstrate there is a better way to either do it or pay for it, and if they do these science projects and if they can find things are sustainable, they actually bring it into CMS proper, okay? An example of this, has anybody heard of the Hospital Engagement Network project? Partnership for Patients campaign. Okay, what happened there was that was a science project over here in the Innovation Center. They brought together all these hospitals. They had them work on improving care coordination, improving patient safety. And then they measured it. And what they found, they hoped that they could save maybe $5 billion, okay? They invested about $450 million. They thought maybe they could save $5 billion. What they saved instead was $19.8 billion, which is about a 40-to-1 return on investment. So what's happening is the feds are going, that was a good thing to do, and they bring that over to CMS proper. The purpose of this program is this is a science project to work with a subset of providers to learn how we can do transformation faster, better, stronger, whatever, but basically, and to try to capture those lessons, and then they will be deployed against the rest of the country. So one more thing to think about is the idea is that there are between 850 and 1.1 million providers in various definitions, doc, nurse practitioner, PA, chiropractor, all these different providers. There's a group of between 850 and 1.1 million who have to transform. This project is about working with a subset of 140,000 physicians and clinicians, okay? So to work with a pilot group, to work with an innovator group. And the idea is to work with them to try to develop the skills and tools needed to improve care delivery so that they can transition to the alternate payment models. To start with people at the MIPS level and try to give them the skills so they can move up to the next level and not lose their backside. Okay, kind of makes sense? Okay, next slide. So the guts of this, it aligns with the Affordable Care Act and the MACRA. Both of those are different pieces of legislation as I described. This is basically, let's build on the evidence and let's kind of figure out how we do practice transformation. I'll talk about that other point in a second. There are a couple of ways that folks can engage with this, either through a practice transformation network or a support and alignment network or through the QIOs, okay? The practice transformation networks are the primary. Physicians, clinicians sign up to be a member of a practice transformation network, and then we bring resources to try to help you basically improve your MIPS score. That's the way I look at it. This thing goes for like 3 years. So it's basically, how do you do the best you can on the first rung of the ladder, and when you're ready, you can go to the second rung. There's no penalty, there's no in cost, there's no out cost. It's just here's some free resources to try to get you ready to climb the ladder when you want to climb the ladder, okay? There are 29 practice transformation networks across the country, okay? So they've identified these contractor groups. I represent Compass PTN. Compass PTN is one of the PTNs, so there are 28 others. Interestingly, we're all in Compass PTN. Compass is the second largest PTN, okay? We cover multiple states. We'll talk about that in a second. One of the things that's unique about us is that we tend to have a very high concentration of rural frontier providers. And one of the things that we're really concerned with is the feds come up and generate all this junk that's going to kill us. So how can we, let's make sure that it works here, and we can, as Dan had said, take the messages back up to make sure that they're good, sustainable strategies for where we are. The goals in this project, again, support clinicians as they go through transformation, improve health outcomes, reduce unnecessary hospitalizations, and sustain efficient care by reducing unnecessary testing procedures. You know, this one's kind of interesting. Reduce unnecessary hospitalization. The HEN project said we're going to reduce readmissions. The SIM projects nationally are working on reducing hospitalizations. Does anybody know why that's so important? Any hospital folks here? Everybody kind of understands that the hospitals are the community, they're going to be the community cost centers, okay? They've been our income generators, and they spin stuff off for the communities historically with all their charges and stuff, but the fact is, they're going to become the cost centers in this value-based care. Here's an interesting thought for you. Nationally, when we look at all the nations, I think most people have heard that the United States ranks 37th with regard to our overall health effectiveness, right? 37th out of all the developed nations, we're 37th. There are 36 other countries that do a better job than we do on quality and effectiveness. However, we're number one in cost. We spend more per capita than any other country in the world, and we should because we're American or whatever. But it's interesting. Do you know how much more we spend? We spend twice as much as the next country, Denmark. They don't even have an army, okay? But we spend dramatically more per capita than any other country, and we get 37th with regard to our overall execution. How did all those other countries do that? We have a healthcare system. The whole system is we have medicalized so much stuff that basically we are very heavily inpatient focused. All those other countries basically have driven care into the outpatient arena. Whether it's your practices are doing things better, or we have things done at home better, or whatever, but basically there is a huge movement to reduce the inpatient and move it into the outpatient arena. That's where the cost is going to come from, and that's why you see this reducing unnecessary hospitalization. If it's necessary, get them. My gosh, I want to go to the hospital if I need to be there, but if I don't want to be there. Hospital's a terrible place to be if you're, they have bacterial resistant all kinds of junk there. So the whole point is that's where it's moving. Next thing, next slide. These are the phases, and you look at this and you kind of go, duh. But this is like, the feds actually have phases that practices will walk through here. This is basically taking practices and teaching them performance improvement so that they are the ones doing performance rather than having somebody. It's not like performance improvement can't just be a science program anymore. It's got to be what we do. Every cycle, how do we make it better and better and better? So this is basically teaching practices to do it. I actually like to say that there's a pre-phase here. There should be another thing where we actually map out our processes. So imagine care for diabetic patients. How do we take care of diabetic patients? Well, put them in a room. Wrong. A little more sophisticated than that. How do we care for our population of diabetic patients? You've asked, and every practice has to kind of map something out like that. And then once you've got that mapped out, try to figure out how you want to make it better. Set some aims. Use data. And don't just use data like, let's look at it in 6 months and see if we're any good. It's more like, let's look at it every month and see how this is working for us. And as we tune this fiddle, does this play better or not? So we continue to make rapid cycle change by looking at the data on a monthly basis. And what's going to happen over time is you're going to start to get better. And as you get better, you're going to be able to start to compare yourself against some national benchmarks. And when you get to this phase, you need to start asking, am I ready to go up to the next rung? Can I now get into a risk arrangement where there actually will be more money going forward? Next slide. So we're here. I mentioned Compass PTN. What is Compass PTN? The Iowa Healthcare Collaborative, I work for that organization. We've been in existence since 2005. We've done all this junk in Iowa, but when this project came along, we recognized that we wanted to take a more regional approach. So we worked with partners in several states, and we have a multi-state approach. So the Iowa Healthcare Collaborative is kind of the lead organization here. We got the contract, but it's pretty hard to do. I mean, how do you guys feel about calling what you're doing the Iowa Healthcare Collaborative? Not so hot, right? Kind of a tough marketing deal here. So we said, let's just make it generic. Let's call it Compass PTN. So we are the Compass PTN, and it's all of us together. Now, to do that, I can do Iowa, but I can't do South Dakota or Kansas. Matter of fact, it would be irresponsible for me to think that we, Iowa, could create a sustainable strategy that's going to keep things going in South Dakota or North Dakota. Okay? So we work with a partner. So we're here with HealthPOINT. And HealthPOINT has been doing HealthPOINT was doing the Regional Extension Center in South Dakota, and HealthPOINT has assumed some responsibility now for North Dakota as well. So HealthPOINT is our partner here, but we also, all of our partners are different, folks, and it's actually our strength. We have an REC and heavy IT expertise. Okay, really proud of that, by the way. Here we have. In these two states, we actually have provider-based hospital physician kind of strategies that are statewide. So these are really strong provider-driven strategies. Nebraska enhances a PHO. It's a big PHO. Okay, physician hospital organization. They contract for stuff. This is 2,200 providers in this one. We have in Oklahoma. It's really weird. We have Telegen, who is a QIO working with the independents. We also have the University of Oklahoma Medical School and the physician group there. And then in Georgia, we're working with the Georgia Hospital Association kind of as the lead there. Interestingly, Sanford has come on board with us as well. So this MAPS, this is instead of, when we proposed it, it was 6, but now we're up to 8 or 9 or something. So, and we continue to have other folks from around the country signing up with us. We have this thing, you look at it, I said we're the second largest PTN. We are responsible to sign up and contract with the federal government 7,046 physicians and clinicians. Who wrote that dumb thing? Okay. And we were pulling our hair out about a month ago. We hit our target. We just, less than that, probably 2 weeks ago, we hit the target. And I still remember when we went over and we were 7,129. And now, it's interesting, now more and more successful. Now people are coming in saying, we want to be part of that. We're now up to 7,700. We have said that we're going to take up to about 8,000 additional members. So, but that's kind of where we are on that. And this is, so I guess the point I'd make is you're part of a big deal. And what that means is there's resources available to you across this whole deal. Next one, Dan. So a couple of things that make the Compass PTN a little bit unique. We're provider-led, and frankly, we've got experience. The Iowa Healthcare Collaborative has been doing this work since 2005, but we were also a HIM. So we have the experience working with the hospital engagement networks. We have the experience working with the hospitals and doing this kind of federal stuff. And in Iowa, dinky Iowa, out of that, all those monies that were saved, we were able to generate about $51 million in avoided costs through improved patient safety. So we know how to do this stuff. Next slide. With regard to you, with your clinics, we meet you where you are. This is not like, okay, here's a cookie cutter, thou shalt do it this way. Well, where are you? What are you reporting? How are you doing this? We need to start with you where you are and then help you identify your point A and help you get to a point B that is better. So this isn't about, y'all have to do all this stuff so you can all get to this common starting point. It's better that we're all trying to meet you where you are and help you improve on your trajectory. Next slide. The other thing is, we also recognize that it's not just your where you are, but you're going to have different stuff. And we want to make sure we have a broad enough offer of resources that some things will be relevant to some and some things will be relevant to others. So we want to make sure that we have a flexible approach and bring to you the things that will help you get to your point. So we have different data pieces. We have different ways of engaging folks. We will have an improvement advisor. You guys want to stand up and introduce yourselves? I mean, did you have a North Dakota person assigned yet? No. Okay, so there's going to be a North Dakota resource, but then Kevin, and why don't you guys stand up and introduce yourselves? Every one of our states, we try to hire folks at a ratio of about 1 quality improvement advisor to every 200 providers. So we want to make sure that we are, you have resources, get them into the onto site, and then we use other resources going forward. And there's a whole bunch of junk that we're going to bring you. Did you say something? Okay, that's okay. No, it's okay. No, go back. Go to the next one. So a couple of pieces here. Your improvement advisor, you'll have somebody who you're working with directly, but they're going to be helping you there's going to be a practice assessment which kind of helps you identify your point A, and then that assessment will kind of work with you on the things we've identified as weaknesses or opportunities and kind of help you using these serial assessment tools. That's how we'll help you improve. We've got faculty with the collaborative, but there's going to be national faculty as well. We have 6 faculty, a couple of docs that have been doing medical home. We have performance improvement folks. I've got a pharmacist on staff. These are all folks that are available to kind of come out and help you if you need it. And then there are going to be collaborative opportunities. This is kind of a learning community, but and this is a small one, but I've run learning communities with as many as 160. We're actually kind of, and what we're going to do today is actually try to form a bit of a community and start to kind of cross-pollinate a little bit, but learning communities, and then we're going to have web-based resources available as well. Next slide. So why would you do this? Basically, it's to improve health outcomes, and you're going to have an opportunity to kind of document those health outcomes through some of the things the feds are asking us to measure now. We want to teach you how to improve, learn how to achieve, and maintain benchmark status. Why? Because with MIPS, everybody's going to be getting better. You could be here right now above everybody else, but if everybody else is getting better and you stay the same, that's going to impact your payment. So we've got to make sure that everybody's getting better. We want to get ahead of the reimbursement curve. Lord knows we want to lose money, so we at least want to stay up with what's going on. And there's an opportunity here to collaborate and lead with local, regional, and national colleagues. Basically, how can we do this different? Next slide. So I want to close. I opened this with Berwick, and again, this is kind of like glittering generality stuff, but if we got to redesign how healthcare is delivered, I mentioned those things that Berwick said about transparency and collaboration and all that stuff. I heard Berwick at a meeting. He came back to CMS and he gave a lecture last December, and he said, "You know, I'm really proud of you. You've really done a lot. You've literally changed CMS." Matter of fact, what's interesting is the way things used to work 10 years ago is the provider community would generate new ways of doing things. We would figure out ways to charge for it. We were able to convince the commercial payers to pay for it, and then Medicaid, and then finally Medicare. That was the way it usually went. Well, where we are today is the system is broken, and the feds are saying, we've got to lead this transformation. They're actually ahead of the commercials and ahead of Medicaid with regard to how we're going to do things different. So Berwick was talking, and he says, you know, you guys are doing so good, and healthcare is beginning to move, but it's just beginning to move. And he says, you know, we're really in a period of radical redesign. And in this period of radical redesign, you need to be thinking. He gave us 10 points of radical redesign. So these are just, as we a provider-led discussion on transforming healthcare. This isn't about, transforming healthcare doesn't mean how I'm going to react to the latest payer change. Transforming healthcare means how are we going to configure ourselves so that we can create a sustainable environment and do the best care we possibly can. Basically came up with 10 pieces. And these are going to sound a little soft and fuzzy, but they're not. They really aren't. This is how we need to do things. Number one, there has to be a change in the balance of power. I mentioned earlier, we don't have a patient-led system or a patient-centric system. We have a provider-centric system. And it's usually, you know, the providers versus the hospitals, or that's the hospitals versus the community folks. And the bottom line is we've got to co-produce this stuff. We have finite resources, and we need to eliminate the duplication. We've got to start working together to do stuff. We have to start focusing on co-producing. Rather than, you know, what everybody does now is everybody's out chasing their own rainbows and protecting their own pot of gold. And now there's only one pot of gold. So we got to figure out how do we actually do this together. Number 2 and 3 kind of go together, and I like to do those, think about those with regard to data. We got a ton of data out there now. We didn't have anything 10 years ago. I mean, it really was just kind of crap. But now we have a lot of data, and the interesting thing is we have everybody asking for stuff all the time. You know, do you have any idea how often we measure the same thing differently? You know, amen. So, I mean, and that's waste and duplication. You know, here's a perfect example. We had, in our hospital engagement network, we asked everybody, okay, we're going to work on diabetes. And what we're going to do, instead of focusing how often we let people get a blood sugar too high, we said, how often did we drive people's blood sugar too low? Because the statistics show that if you focus on over-treatment with glycemics, it's amazing how this comes down. Okay, the blood sugars come down by watching the total range. Focus on over-treatment. So we said, how often do you get a blood sugar less than 50? Hospitals, we know it's a major harm error in the hospitals. So the hospitals are working at how often did we give someone too much insulin and their blood sugar dropped below 50? You know what happened? What we learned, we had 127 hospitals, and they ended up falling into 3 different families of how to report blood sugar less than 50. They all used a different denominator, some per 1,000 patient days, some per number of patients. So we actually went through 2 years of just trying to get everybody to use the same denominator. It's a wonderful opportunity to say, wait a minute, we can't even talk to each other if we can't standardize how we measure it. So we need to standardize. Everybody got that? Okay. But we've never done this value stuff before. And there's going to be new measures that we've never even considered before. I don't know how, I mean, we're going to have to figure out what are the new custom measures that we're going to have to be innovative with some measures. So we're going to have to we're going to have to standardize what we can standardize, but we're going to have to be creative enough to come up with new customizations. So we're going to have to do it together. The faster we can come up with cool stuff and then standardize it, that will be our success point. Promote well-being. Yeah, right. Sounds kind of public healthy. you know what? We don't really promote well-being. We promote being well. And if you're not well, by the way, what's well? I don't know. What's well? Not sick, right? So I'm out trying to find sick people so I can make them well. All right, but it's back to the medicalization. The whole point is, hold it a second. We got to think about the whole picture here. Are people really? Are we thinking about how we can promote the whole person, not just the non-sick people? So it's just be thinking about there are so many things that drive healthcare costs. We need to think beyond just finding sick people and fixing them. Okay, joy in the work. You guys are here, right? I mean that like, you know, if you're here, you're probably pretty smart, but you probably could have made a lot more money doing something else in healthcare. I have a kid who's a healthcare administrator in Omaha, and I remember when he went to school, he graduated with a degree in psychology and business degree, and he got this great job with Target Corporation. And he was going to be a store manager. He was going through the store manager training program. By the way, those guys get paid well. Do you know that? I mean, that's really a cool program. So Chris is getting up and he's driving, and he has to be there at 4 in the morning and turn all the pineapples over or whatever. He does all kinds of stuff. He's working in the food thing. But I remember getting a call from him about 7 months into this program. It was like a 1-year program to become a store manager, and he said, I think I'm gonna apply and get a master's in healthcare administration. Where'd that come from? And he says, well, you know, this business stuff is really, really good, but I want to do it in some place where it feels good, where I feel like I've done something for people, where I feel like I've actually contributed to something besides just selling stuff. And I just want you to embrace something. We think about what we do every day. We do cool stuff, and we help people every day, and it's an important thing. Next slide, Daniel. These last 5 make it easier. This kind of talks to the waste, and I'm not here to promote one performance improvement religion versus another. There's TQM, there's PDSAs, there's Lean, there's ISO 9000, there's all these different, everybody's heard of all the programs, right? There's a gazillion different programs everybody's selling. I call them religions. But the fact of the matter is we need to reduce the number of steps that we do things because our processes are too complicated. And they get complicated because we have to have more and more stuff added on to make sure that we're doing the right thing. Just what you were talking about earlier. Hey, you're making the cost higher because you give me so much crap I have to do in addition to stuff. Here's an interesting story. You know, there was a process map done on how many steps it takes to put in, from the time the doctor decides he's going to give a patient an aspirin till the time it's in the patient's mouth. They process mapped it out. 17 steps. Now, if every one of those 17 steps
There are 5 parties in the conference. You will now be placed into the conference. This call is being recorded.
17 steps. It's only a 50-50 chance you're going to give someone an aspirin correctly. Okay? The whole point is how you improve this is decrease the number of steps. Get rid of the wasted stuff and figure out how you can do it in less steps. Pretty simple. How do we do what we're doing with less steps? Modernization. Everybody understands modernization, but not really. Dan heard this the other day, but I had cable put in, or I had satellite TV put in recently. I thought it was really cool. Satellite, you know. So, but when I moved into our house in 1988, we had cable, and I bought this house. And we did dinner. It was probably a 10-year-old house, but I was so proud because it was already wired for cable. I had cable wires all over the stuff. So we put in cable, and but then I had like 2 TVs then. So then we added another TV, and everything gets fuzzy. So I got to put a booster on it, and then I decided let's put a TV in the kitchen, and so we put another TV in, and then more TVs and more splitters and more boosters and more. So the signal has to be split and boosted and split. My house got cable all over. Then we added an addition, so now I had 3 more TVs added. anyway, bottom line, we had a whole bunch of TVs, a whole bunch of cable, a whole bunch of splitters, a whole bunch of stuff. And I'm thinking, well, we went through a store and they said you should be thinking about satellite because it's a lot cheaper. Okay, so we're going to put satellite in. The satellite guy comes in and he says, okay, where do I hook up? And I showed him and he goes, oh, well, we can't use all your cable. I mean, every one of those splitters and boosters, you have to have a separate satellite splitter and booster, and that would be, man, that costs you like $1,000 to do all that stuff. Well, I'm not sure I want it then. He goes, well, but what we could do instead is we can hook up the satellite on your roof and hook it up to one TV. And then there's this thing that communicates with all the rest of the TVs through IR. So it's just like through the house automatically. It's just done. And I'm thinking, oh, that's really cool. So we have now, it's hooked up for one TV, and now the signals magically talk to everything else. And it's modern. And I have a house full of cables and splitters and boosters. But the whole point is there are new ways to do things. There are other things that we need to, a lot of the time we don't change because we don't really know how the new things could be better. So we need to be thinking about that. Collaboration is obvious, but again, so often we don't collaborate in healthcare. And if you don't get anything else, I don't care if you're here with a QIO, if you're here with a hospital system, if you're here with a doctor's office, if you're here with a federally qualified health center, I don't care. Get over yourself. Because we got to figure out how we do this. It's going to take all of it. There's no one else in this environment like you that, I mean, you guys understand your payers, your patient population, all the uniquenesses. Your statutory environment is unique. So together, how do you build the solutions you're going to have? The last two are, you look at those and you kind of go, oh, here he goes in the finance stuff. But the fact is, we need to assume abundance. I already mentioned that we're 37th in quality and #1 in cost. We have enough money. We got to figure out how we redo this stuff. If we can just eliminate the waste and duplication in the system, and I'm not just trying to be a lean proselyte, but we have so much extra crap in the system that it's just, again, 40% of the system is estimated to be waste. Let's get rid of some steps. Let's get rid of some stuff. Let's figure out how we work together to do some things. The last piece was kind of an ethical, moral perspective that Berwick talked about, but he described an experience that he did where he ran for governor for Massachusetts. And he presented this nice big graph on Massachusetts expenses. And I bet yours looks the same. And he has on one of the lines on the graph was expenditure over time for Medicaid. And it was an upward trajectory. Medicaid cost, it's just, and think of that as a sampling of healthcare costs because it's just going up. But then on the same graph had two other lines. One of them was for legal law enforcement, was doing this, and the other one was for education. Okay? And he put a term to it. He called it confiscation. And, you know, we have healthcare costs that are kind of out of control, driving, going. We have an ethical and moral responsibility to try to figure out how we do this better. Not just because, I mean, it's because we're not spending money on things that we should be spending money on. Anybody ever heard of ISIS? Or anybody real happy with our educational system? I mean, there's some real opportunities here that we're beginning to underfund some pretty important components of our national infrastructure. And it's really about us trying to figure out how we do this differently. So next slide. Still alive? There we go. So what I want to do, so let me go back to the previous slide. So I want to stop there for a second and just, I beat on you pretty hard for a while here. So questions and comments, thoughts, pushback, discussion. This mom and apple pie, or are you going to like say, Dan, where'd you get this idiot? Or anything, comments? Yes. Yeah, I really thank you for saying that. but I want to camp on something that you said. You know, so much of what we're doing right now, a lot of what we're doing right now is this is going to be focusing on the provider community so we can kind of tune the fiddle with them. And it's not just about MIPS. This is about leadership. And stick with me on this one, because what you just described is community-based healthcare. Do you guys like have to execute that? Is that like, do you guys get that? You guys don't, you've got resources in your community, but you only have X amount of resources, and you guys really care about how you execute them locally. But you've got to actually bring all the resources together and run plays together, okay? So it's about building those community-based strategies, because only the community-based strategies will be sustainable going forward, okay? And by the way, do we care about that? Because most of us would like to have a hospital close and want to make sure we have the resources locally. So you got to do that. So it's about population-based, community-applied strategies, okay? But the other piece is, so are we going to lead it, or are we going to have the payers write the stuff and then try to just incentivize us to do it? And my point is, okay, we got to pick up the ball and we got to run with it. And if we don't lead, the provider community doesn't lead, who will? So, thank you. Good point. Other comments? Well, the way we structured this in other places, what we do is I give this lecture, and then we would turn you loose to kind of go catch your breath somewhere, and then we do another lecture, and then we would bring you together and give you a series of questions called table talk, and we'd let you kind of interact with each other. For this meeting, we decided to make that different. So what we're going to do is, I'd like to have you to get together in groups, and I don't care how you arrange yourselves, but you ought to think of groups of like 6 or 7 probably, and so kind of rearrange yourselves. And what we want you to do is talk at the table about how the next slide, Dan. This is the question I'd like to have you consider. What are you doing to prepare for macro? And different people are doing different things. You may be representing different pieces, but just have a discussion about how you're getting ready for macro. And what we're going to do is have you talk for about 10 minutes at your tables, and then we're going to kind of do a facilitated discussion here together. And then we'll take a break after that. Okay? So kind of get together in groups of 6 to 8 and kind of kick it around. By the way, there are no right answers and there's no wrong answers. And there's no embarrassing anybody.